Hello, I am Matthew Loscalzo, Executive Director and Professor of the Department of Supportive Care Medicine in the City of Hope in Duarte, California. I am incredibly fortunate to be sharing this panel with my colleagues from Africa. We have deep connections that we have in terms of wanting to help others and trying to relieve the suffering of those people impacted by cancer. Probably the most important conversation we can have now, though, is how do we support each other in such challenging circumstances? So we have a wonderful panel who are about to introduce themselves, and I'm going to ask Roselyne to be the first one to tell us about her work and what she does.
Hello, everyone. It's my pleasure to be in this panel. I am grateful to the organizers. My name is Roselyne Okumu, Oncology Nurse Specialist, practicing at Kenyatta National Hospital. And my workstation is the chemotherapy center, where I lead the nursing services there. I am also the Oncology Nurses Chapter chairperson in the country.
Thank you, Roselyne. Thank you. And next will be on my screen will be Kwanele.
Good afternoon, everyone. My name is Kwanele Asante. I am a lawyer and bioethicist by training, but for the purposes of this panel discussion, I am a person in remission for breast cancer living with chemotherapy-induced cardiomyopathy. And I look forward to this conversation. I'm based in Johannesburg, South Africa.
Thank you very much. Naa.
Hi, everybody. My name is Naa Adorkor Aryeetey. I'm a radiation oncologist, actually a clinical oncologist from Ghana. I work in the Korle Bu Teaching Hospital. So I'm responsible for seeing cancer patients, solid tumors mainly, both pediatrics and adults. Because I give radiotherapy to pediatrics, medical oncology is a different specialty. And then I give radiotherapy as well. I help with teaching the other residents and some nurses, and I love my job.
Thank you very much for being here. Benda, you are next. Can you introduce yourself and tell us?
Hi, Matthew, and hi. Thank you. My name is Benda Kithaka. I'm a health advocate from Kenya, situated in Nairobi. And my work is on policy advocacy to address the late presentation for patients, and as well as addressing quality of life for cancer patients and cancer survivors. My interest is on behavior change communications, so that we can be able to get our people to appreciate how we can minimize risks and also address the late presentation in cancer, which has an impact on survivorship as well as an impact on treatment outcomes. And so my advocacy work is more of working with people with living with conditions, chronic conditions, to inspire them to tell their stories for impact, and to also impact survivorship and impact policies that can address the challenges that we face in our continent. Thank you.
Thank you very much. What I'd like to do is I would like to start with Kwanele, because her experience informs everything else. And really, Kwanele, I was hoping if you'd be so kind, can you share with us, really as a person who has experienced the healthcare system, and I know they really vary greatly across countries, but as a person, what do you most want people to know about your personal experience?
What is most important for me is, since we're talking to clinicians and researchers, is that as an African cancer patient, I am very interested in being included as a partner in health communication. You know, I was 37 when I was diagnosed many moons ago, but it was very difficult to get that initial diagnosis because scientists or clinicians in this instance were more focused on doing the risks and excluding risks factors that I was asked. So you're Black, you have had children, you are 37, you have no family history of breast cancer. Therefore, you shouldn't be concerned. So what I want us to know is, you know, clinical indications are important, the risk factors are important to exclude. But I would like more empathetic listening. And within our African context, I think it would be very important to educate patients on what cancer is and what cancer is not. The job should be done by our state parties, our countries, but countries are not very good at educating patients about, or even lay people about what cancer is. And that's why we end up with stigma and misinformation around cancer, the disease. It is important that we educate the patient. And finally, I am very excited that we are doing this in the context of the Best of ASCO. When I was diagnosed as a private health sector patient, I had an oncologist who was a member of ASCO, and he asked me, "What kind of patient are you?" And before I could even answer, he said, "I know what kind of patient you are. You are somebody that's going to want to be included in your own care." So because I can see that you can read and you're worldly, you have that weird American influence twang. He said, "I want to show you this website." And he took me to the ASCO website. And this is 2006 in Africa, Johannesburg. And he showed me the tab where they had information for patients about breast cancer. And he said, "You know, this is going to be your resource. Read this." And it was because of my ability to read and ask him questions about what I was reading. That's how we picked up the cardiomyopathy. But let us go to a new context that even the African patient deserves to be within ASCO corridors, deserves evidence-based information. You know, they need regular access to reliable, culturally appropriate information. I hope that answers your question.
Well, that goes well beyond answering that question. That was a beautiful response, and I want to thank you very much, because I think that's going to be the core of everything we talk about, because this particular panel is focused on supportive care. And so inclusion and partnership, the ability to get information that you can use, seeing past illness to the person and managing stigma, these are international issues in every country. And so thank you for laying out the groundwork for us. I'm gonna ask Benda to go next to give us some sense, because this leads right into advocacy. Benda, how do you advocate? And how would you recommend that the oncologists and the nurses and the health educators on this call and the advocates, how would you recommend that they engage the system to be able to pursue these goals that were so beautifully just laid out?
Well, I look at Kwanele's answer and response about being involved individually and also being involved as a patient. And the way we advocate for our patients speaks into what Ms. Kwanele is asking for, that the clinician, the health practitioner, sees the patient as a partner in this journey. The clinician has the biological, the scientific knowledge, but this patient has their own experience to go by. And therefore, when the patient comes and says, I am feeling this way, let's pause and listen for a moment and understand that this patient is an individual. They are not all the textbook case scenarios that we see as a clinician. They are actually an individual person who has a lived experience. And I'm speaking into this because for me, when I look at involvement, it's also about meaningful involvement. Getting the patients to be able to speak what they feel, to also be able to question the decisions that are being taken. For example, when a care plan is given, let the patient also be able to question, why this option for me? I have seen cases where patients can present late with breast cancer, and regrettably, a patient is told there is not much more we can do, and then they are sent back home. Chances are this patient has questions about there is not so much more we can do now, but what else is available for me as a patient? When we send away a patient because they've presented late, and because those are exactly the words that they are told, you have presented late, this cancer is late stage, and quite a number of them do so. Regrettably, we're placing the blame on the patient as opposed to scrutinizing what are the challenges this patient has had to present at the time that they have. And if we were to utilize that patient's example and look at removing the barriers, look at removing the blocks that made this patient present late, one of the things Ms. Kwanele has spoken into is patient education. If we remove that element and we make sure that all other people understand in the community that it's in their best interest if they were to present early, because then the treatment will be easier, it becomes this one patient, yes, there is not much we can do, but there is so much more we can do for the others. The second thing I would speak into is to look at patients as partners. In essence, when I say partners, it's not so much about let's sit and consult. Yes, you are the expert as the clinician. The patient is presenting with a disease, but also they are agents of change to the community. They're the ones who will go back with their lived experience to speak into the community about prevention, about early detection, about treatment options. And therefore, if we equip the patients with the right information and give them the right voice to speak out, they will be a better partner at the community to advocate with us, as opposed to all of us trying to be in every place at the same time. That's what I would speak into at this point in time.
Okay, Benda, I want to thank you because both of you point to what we would aspire to do, and that's an essential element. And one of the things we're going to do, and that's why I'm going to ask Dr. Adorkor to go last, that what we're going to do is we're going to go even a little bit deeper to see what the challenges are on both sides, because these are real challenges that we all face in every country. So I'm going to go to Roselyne next, if that's okay, Roselyne. What do you want to tell us about your experience and what you do?
I have worked in cancer care for almost 11 years. It wasn't planned. When I got my second job at the National Referral Hospital, I ended up going to the medical ward, which also was doubling as the oncology ward. And I had a chance to see several patients. We had the hematology, hemato-oncology, and the solid tumor cases. And we got used to the patients because of their kind of treatment regimen. Because we were mainly doing chemotherapy, we would be able to anticipate somebody coming in the next 3 weeks, somebody coming in the next 8 days. And so in a way, we developed a relationship. The most interesting thing was seeing the young girls and boys, teenagers, coming in with the cases of lymphomas and leukemias. I remember there's this particular girl who came in with her school uniform, and she had a diagnosis of leukemia, and we established a rapport. After we did the induction treatment, the side effects were overwhelming. She started bleeding endlessly. And at that time, we had a challenge with getting the blood and the blood products. And that means the girl, as much as would get some blood and platelets, it was not sufficient. And so unfortunately, that girl just died a while after the treatment started. I was so hurt. I thought this is not fair for a young girl of that age. And I thought as a nurse, I needed to do more. And with that, I opted to go back to school and do oncology nursing at a master's level, hoping to be able to add value to the patients and more so to add also value to the policies of the nation, which I've been able to participate in. And going forward, I've also worked in the cancer center, having graduated, where I've handled patients going through radiotherapy, and now at the chemotherapy center. I have seen patients coming from different backgrounds. Patients are so unique in the way they present. And at times when the workload is a lot, you realize that some of us may not be able to get all the information we require. So one of the things I've tried to do is to sensitize my fellow colleagues, especially the nursing team, that we need to do more assessment. And we try to do the nursing process. We assess our patient, we make our nursing diagnosis, we look at the lab works, the other investigations, and we come with our plan of care. And so the nurses are able to quickly identify anything that probably qualifies the patient to get a more personalized care, and maybe something that maybe the doctor may have missed that requires maybe withholding of chemo. As you've talked of, maybe somebody like our colleague, she talked of having gotten a problem with the cardiomyopathy. So in a way, we have been sensitized. We know which is which investigation to be done. Is it done? Is it within the normal limits? How are the chemotherapy calculated? How is the patient presenting? Even though it is calculated at this rate, is the patient stable enough to withstand the chemotherapy? We have tried to use our own assessment and judgment in collaboration with our medical team. And in this, patients are getting individualized care. Some of our patients, though, come very late in presentation, and we have to know what is the aim of this treatment. Is it for cure? Is it for control? Are we just palliating? You get a woman coming in with the fungating breast cancer wound, and she has one T-shirt and it's already wet and soiled. So then we start by doing the dressing, giving her a dress to put on, and now she feels more confident. And then she becomes more confident and able to sit with the others and interact through the process. And that makes them even have more quality of life and makes them to desire to come for the next cycle. And some of them we talk, we become friends, we tell them, do you allow us to take a photo so that you compare with their next appointment? And they do agree. And when we look at the wounds shrink, we are encouraged even as a team. And so we have learned to put the patients first. We have learned to allow them walk the journey. I mean, we walk the journey with them so that we are there to answer the unique challenges they're going through. And we allow them to know that they're always at liberty to ask us questions. Also, in our cancer center, we have multidisciplinary team. We have navigation nurses, and these nurses try to give information to the patient on the time of diagnosis. At times, you realize that it may not sync as well, so they have to do the second encounters, and then they give the information and education and communication material which have been developed. And they go a long way because when they go home, then they're able to refer and also to contact the nurses in the navigation program so that they are helped even while away from the hospital. That has been my experience and so many more. We have come from a state where things were looking so bad, and I can say there is hope because we came from a place where, am I answering too much? Can I go on or I stop there?
Okay, why don't we stop here at this point? Because we're going to come back to you. We're going to come back to a few other questions. We only have about 15 to 20 minutes left. So I have, by strategy, really waited so we could, so really Dr. Adorkor could tell us the physician perspective. Because as the captain of the team, you're hearing all these expectations and all these desires, and everyone on this call has a heavy load to carry. But we know that the physician has the leadership role in most places, certainly everywhere I have been. And can you tell us a little bit about, to all of your colleagues, what is it like as a physician to hear this and to hear all the complexity of what everyone else is doing? But I want you to be personally telling us, what's your experience like?
So the first thing I thought about after hearing everybody is that there's a lot to be done. Sometimes we assume that our patients won't understand us or they won't understand the science. But often it's not about the science, it's about making them comfortable enough and giving them enough information that they trust what you're going to do. There have been so many times where patients have come into the consulting room, you've had a discussion with them, and unfortunately in Ghana, for example, the doctor is seen almost as a demigod. So the patients may not be able to ask you questions. And when they enter and you start speaking English, a lot of patients don't understand English, or even if they understand English, the things don't mean the same to them. So over the years, what I've noticed is that when you welcome a patient in and you make them comfortable, then they're able to express everything from their fears to their hopes. And when I hear the advocates talk about making sure that even when the patient has come in at a late stage, that they don't feel like they are being victimized, that is really important, because they face so much discrimination outside of the hospital that I think it's unfair that when they come to the hospital, they should experience same. So I always tell the story of a young woman who had gone to, and the truth is that in Ghana and maybe in other parts of Africa, the doctor is in competition with spiritualists and traditionalists. And so for this patient, after she had been diagnosed, she was young, 32 or so. She wasn't comfortable with the diagnosis of breast cancer. And so she went first to her pastor, who said to her, if you have surgery, something will happen to you. Then she went to the traditionalist who tried certain things. Now, the first day she was coming to the hospital, when she came in, she was in tears. One of our nurses, Naomi, a phenomenal woman, she called her and asked her what was wrong. The sad thing was that, she had a fungating ulcer that was foul smelling. And the public transport she used, in the middle of the travel, they asked her to get down. The other travelers in the car, in the bus, asked her to get down because she was foul smelling. And so for such a person, once she came in, the most important thing was not that she had breast cancer. The most important thing was encouraging her and giving her hope. And unfortunately, because it was advanced, she eventually died. But what gave me satisfaction was that we saw her from somebody who was crying all the time to somebody who was suddenly happy to come to the hospital because the wound had healed and she didn't have problems in a public bus. For her, that was the most important thing. So I really do think that as physicians and as team leaders, yes, we are responsible for telling the patient what the disease is, what your treatment would be, but we are also responsible for making the patient feel welcomed into our space. And really, it's our space. When they come, they feel foreign, they don't feel a part of it, of the system. But it's our duty that we make them feel a part of the system. And once they feel a part of the system, you'll be amazed. They are the ones who get other people to come to the hospital. In the past, we've used our survivors to get other patients to start treatment, to continue the treatment. And it's only because they feel like they're part of the system. And so that's what I would like to say to everything that you guys have said. Inclusion is the most important thing.
So it sounds to me like we all agree that inclusion really does matter, that being partnership, getting accurate information, seeing past the illness to the person in their social context, and recognizing, as you just pointed out so beautifully, about stigma. And these are international. These are international issues in every country, but they vary in terms of what they look like. I just want to ask you, and then we'll go back around the same way that we just did, so everyone gets one more chance to speak. What gives you hope for the future? I'm going to ask everyone this, because we hear that there's sadness, there's death, there is personal illness. It impacts you, it impacts your family. This has got to sort of wear us all down in every country. But we respect that there are differences. So, Dr. Adorkor, let's go with you, and then we'll go right around the circle in the same order that we did, so everyone gets to, what gives you hope for the future?
There's so much hope. So when I've been an oncologist for 10 years, I can't believe it. Every time I say it, I'm like, oh my gosh, I'm that old. So I went into the radiotherapy center because what I really wanted to do was radiology. But then I thought I wanted more intimate clinical care. So I went to the oncology unit to just work there for a year. When I got in, in my center, there were 2 consultants who had been trained outside. And then there were 2 young residents. And I was the only other person there. And there were so many patients who used to come in. And the clinics would go on for long hours. I wasn't sure how they were going to manage, because I could only imagine that the numbers were going to go up. Well, fast forward 10 years later, the Ghana College of Physicians and Surgeons has a program for oncology. Right now in my center, there are about 8 residents. That's the first year residents. And so I can imagine that in a few years, we'll have radiation oncologists outside of the capital. So there are 3 centers in Ghana, 2 in Accra, 1 in Kumasi. Right now, I am rest assured that in a few years, there will be radiation oncologists elsewhere. When I started radiation oncology, I read about Herceptin, for example. Currently, Herceptin is on the National Health Insurance. So even though we started from not such a great place, and I'm so proud of those who came before us, because even though they lacked, they did their best. But over the years, what I've realized is that a lot more effort is being put into oncology care. We have more people who have lived after treatment and are making all the noise that's necessary. And so I feel like the future is really bright. In a few years, I am hoping that every option for treatment will be available to every Ghanaian patient.
Thank you. That was beautifully said. Thank you. So we're going to go back to our colleague Kwanele to really get a sense of what gives you hope as a person personally for the future.
We have come a long way as African researchers, clinicians, and patient advocates. I am very hopeful for the future because we're having this conversation. I started being an advocate in 2006. And at that time, doctors like Dr. Naa were rare, doctors that said, come in. This is my big English for what's going to happen to you. You're going to lose your breast, but it's called a mastectomy. It sounds, I always say it sounds so beautiful, but it is quite a brutal experience. So when you have doctors like Dr. Naa saying, I want to educate you, I want to help you navigate this system of healthcare And I want you to make sense of what has befallen you. So that we are here as Africans, engaging with an international audience, we're able to say we want a patient's voice, we want an advocate's voice in the conversation. That African cancer stories are being told at ASCO level, that there are organizations such as the African Organization for Research and Training in Cancer, which is a scientific organization that Benda and I belong to as lay people. And I would be remiss if I don't say that I'm the Secretary General of Aortic. All this was impossible when I started going to my first Aortic in 2009. It was a place swimming with doctors, and I was the odd voice out. However, now there is an express invitation, like you have done with the email, to say, please, we're doing the best of ASCO, but please come in as a patient voice, come in as a survivor, be in conversation with the clinical team. So I'm very hopeful that from this beginning, we are going to build going forward and bring more and more lay people into the conversation as partners in health. I'll keep saying that until I retire, as partners in health, because it's very important that we understand the patient's perspective and we help them understand the world of science, especially within a culturally dynamic environment that we are. Finally, what gives me hope for the future is that hopefully we're going to stop labeling patients. I want to see us get rid of the notion of late presentation and understand the social, cultural, financial implications that keep people outside the healthcare.
Thank you. That was so beautifully said. It's great to have an attorney on the panel who are able to so crisply say things. We're going to go to Benda now.
Matthew, what gives me hope for the future is listening to Ms. Kwanele, listening to Dr. Naa, listening to Roselyne, speaking the same voice of patient inclusion. That gives me hope because it brings a concept of collaboration where we all want the same thing. Yeah. Let me tell you, when I came into the field of advocacy, I was coming from a communications background, corporate communications. I came into the field speaking cervical cancer. First of all, culturally, we don't speak about things below the belt. And here we are talking about cervical cancer and saying that we need to prioritize it. In the 9 years that I've practiced cervical cancer advocacy in Africa, we have seen the WHO take on cervical cancer and say it's a one cancer we can eliminate from the face of the earth. Now it's going to take work. And so for me, the future looks bright in the sense that we have lots of political goodwill, policies at high places. We have lots of goodwill, policies that need to be adopted to be culturally acceptable and also easily implementable in our local situations. So that when we are saying the 90, 70, 90, for example, how does that translate into a country which doesn't even have a national cancer control plan in place, compared to a country that has a national screening program in the Western developed countries? So looking at that cultural aspect is critical. And for me, what gives me then hope in these policies being brought in is listening to Roselyne, listening to Kwanele, listening to Naa. I see all of us want the same thing. And what then we ought to be working towards is each one of us speaking from the same voice, calling on our governments to ensure that they put resources in place so that our patients are guaranteed that they will get the quality service that they deserve. And that way, the future will be easier for each one of us practicing. for the advocate, we'll have less of going to the communities to get people to get screened, because that is already happening as a government policy. For the patients themselves, we'll have less of that late presentation because policies are in place being implemented to ensure that we can capture the patients as early as possible. Community education is happening through health promotion. For the clinicians practicing, Roselyne and Naa, there will be a hope that we all want patient outcomes that enhance quality of life. And therefore, what I hope we can do so that that hope is realized is that we can all see ourselves as agents of change, clinicians as advocates, and everybody seeing that we advocate. Every single day we wake up, we are working towards making the situation better for ourselves and for the people we serve. And that can only happen when we have a unified voice for advocacy. Thank you.
Thank you, Benda. Thank you. Beautifully said. Beautifully said. Roselyne, I want to make sure we get to you before we end and sum up. So please, please tell us about your hope for the future.
Okay, what gives me hope is being able to see some of the patients we have handled the past 10 years, the past 5 years, still coming back for our follow-up clinics. And we are able to touch base and find out how they are doing, and even find out how much they're able to help the others who've been diagnosed with cancer. You know, because when they talk to each other, then they're able to give the support from experience more than what a healthcare worker like me would do. And that motivates even other patients. So one of them is that. The other things is, as per our country, Benda has spoken a lot. However, we have seen the government goodwill in our country. There's improvement of infrastructures in terms of establishment of new cancer centers, so patients can easily access. There is improvement in human resource capacity building. We're having in-country training of medical oncologists, clinical oncologists, nursing oncology, and that is embraced. So we hope that even as we grow older, we'll get a team that will be able to continue with the work, and that will be able to be more experienced even to handle the patients at a personal level. Yeah, and more so also the screening programs of the cancers amenable to screening, because now we are trying to embrace our national cancer screening guidelines, which has given specifics of what we need to do. So I know that with all this, we'll be able to detect cancers early, and we'll be able to give better quality in terms of management. Thank you.
So because of time, we have to end, but I just want to say a few words. I think the best of ASCO is on this panel. I think the best of humanity and expertise and compassion is on this panel. So what gives me hope is when I hear us speaking, and across the world, we're all struggling with very similar issues. Clearly, there are resource differences. To sort of look the other way is delusional. But when it comes to spiritual connection that we all have, and the intellectual curiosity that I heard shared with this wonderful panel, it gives me a great deal of hope. And what I'm hearing loud and clear, and what Dr. Adorkor made very clear, is we have to make some noise. We have to make noise that is scientific, that is based in fact, but also based on humanity. And we need to join all of those. And this is what I've heard from really all of you. Again, I want to say the best of ASCO is on this panel. It was a total honor to meet you all. Thank you so much.
Thank you.
Thank you, Doc.
Thank you, Doc. Thank you.